Okay. So, parasitology is another branch of microbiology which is important for entrance. Recently it is increasingly asked. The reason is image based MCQs. The image based MCQs are so much from parasitology, that is why the number of questions are relatively more nowadays. But it is not a difficult topic, it is a light headed topic. So, whenever you are feeling bored, you can open parasitology and read, and it is not very difficult. So, general parasitology you can read by yourself. I will start from individual topics. So, let us start with amoeba. Amoeba broadly they are categorized into intestinal amoeba and free living amoeba. Intestinal amoeba pathogenic is Entamoeba histolytica. Non-pathogenic is Entamoeba coli, and although there are various other non-pathogenic amoeba are available. Free living I will discuss a bit later. So, now let us start Entamoeba histolytica. So, histolytica, any parasite when we discuss, if you talk about the life cycle, then there are certain questions you have to answer first. That is, what is the habitat of the parasite? What is the infective mode, infective form? Which is the diagnostic form? Which is the pathogenic form? Which is the mode of transmission of the parasite? So, these are the questions which should be answered first. Then only it is easy to discuss the discuss the life cycle, or even the summary of the life cycle will be these questions what they can ask. As far as Entamoeba histolytica is concerned, you know that it is a large intestinal parasite. The habitat is large intestine, and it has two forms. Two forms are there, trophozoid and cyst. Infective form is what? Cyst also will have immature cyst, that is immature cyst will have 1 or 2 nucleus, mature cyst will have 4 nucleus. So, which is the infective form? Yes, quadrinucleated cyst. So, the quadrinucleated cyst, of course mode of transmission will be fecal-oral mode, following which the quadrinucleated cyst in the small intestine will undergo excystation. When it undergoes excystation, trophozoids will be released. Trophozoids, they go to large intestine, and as I told you, large intestine is the habitat of Entamoeba histolytica. They usually reside in the large intestine. In the large intestine, the trophozoid, when they go, trophozoid will have virulence factor on its surface which are called as lectin antigen. These lectin antigens are the adhesins of the trophozoid by which the trophozoid are adherent to the large intestinal mucosa, and that leads to various pathogenesis. So, if they ask which is the pathogenic form, trophozoid or cyst, answer is trophozoid are the pathogenic form, because they contain the virulence factor, they express the virulence factor called as lectin antigen by which it binds to large intestinal wall, and following which it can cause all the pathogenic process in the intestinal wall that leads to formation of flask shaped ulcer, in the intestinal wall, granuloma formation which is called as amoeboma. Amoeboma is a type of granuloma formation, and further multiplication leads to invasion of trophozoid. Invasion of trophozoid can cause GI perforation also, sinus formation and perforation. through which the trophozoite can invade and they migrate to extraintestinal site. Which is the most common extraintestinal site? Liver. So, which is the pathogenic form? Answer is trophozoite. Which is the invasive form? Answer is again trophozoite. Which form goes to liver? Again trophozoite. In liver, which forms are seen? Trophozoite, cyst, or both? Answer is only trophozoite, because cyst is never formed inside the tissue. Cyst is formed in the favorable or unfavorable condition? Unfavorable condition. Inside the body always you will have a favorable condition. So, trophozoites will be attached to the GI wall and they want to come out of the body. They come to the lumen and the lumen they will be transformed to cyst. Cyst initially will have immature cyst, gradually they will form tetranucleated mature cyst. And as far as the release in the feces is concerned, feces both immature and mature cysts are released, and cysts are the usual diagnostic form. Cysts are the usual diagnostic form. Most of the time cyst will be released, immature and mature. But which is the infective form? Only mature. That means what happens to immature cyst? Immature cyst, once they are released in the environment, they will become mature cyst or they will get disintegrated. Yes, they cannot, immature to mature cyst can occur only inside GIT. Once they come out, they will be disintegrated. Okay. So, the usual diagnostic form is cyst. Most of the time cyst will be there, but the thing is, cyst if it is present, you cannot differentiate whether the infection is active or not. Most of the cases cyst will be there in carriers only. It cannot differentiate the disease is in active stage or not. Once in a while, very rarely, the trophozoites also can directly be seen in the feces. Presence of trophozoite, though it is rare, but it indicates, it confirms active infection. Okay. So, this is what you have to remember. So, carriers are the, cysts are the routine diagnostic form, but they indicate carrier state. They cannot differentiate active and carrier in stage, whereas trophozoites are released once in a while, but if they are present, they confirm the active infection. Okay. So, this is all about. Then regarding the lab diagnosis is concerned, say that stool examination is done and you take at least 3 consecutive stool samples. And if you do a stool microscopy, how the cyst and trophozoites they appear? They say that you have to differentiate the cyst and trophozoite of Entamoeba histolytica with that of Entamoeba coli, because Entamoeba coli is the most common commensal in your GIT and often it will be confused with Entamoeba histolytica. So, they say that trophozoite of Entamoeba histolytica will have a finger like pseudopodia. They have a finger like pseudopodia, whereas trophozoite of Entamoeba coli, the pseudopodia is blunt pseudopodia. This is one of the major difference. And please remember, trophozoite will not have any shape. They are motile. They are motile structures. They will frequently change their shape. So, any shape you can draw. How to differentiate the cyst? the cyst of Entamoeba histolytica is round, 8 to 10 micron in size, and matured cyst has 1 to 4 nuclei will be there. Whereas E. coli, it is also round but larger in size, 20 to 30 microns in size, and nucleus maximum up to 8 will be there. Maximum up to 8 will be there. How can you differentiate individual nucleus of E. coli and E. histolytica? If you take only one nucleus of EH, one nucleus of E. coli, how can you differentiate? They say that EH, the nucleus is lined by chromatin dots. The nuclear membrane is lined by fine peripheral chromatin dots, and the karyosome is central. The karyosome is central in nature, central karyosome. I am drawing the inside structure of the nucleus. EH, the nuclear membrane is lined internally by fine peripheral chromatin dot, and it has a central karyosome. Whereas E. coli, the peripheral chromatin dots are coarse. Okay, and the karyosome is not central, it is eccentric. Eccentric karyosome. So this is how you can differentiate inside of nucleus. The individual nucleus of E. coli and EH can be differentiated based on these properties. Okay, and please remember that the Entamoeba histolytica, cyst and trophozoites, if you get, can you say that it is pathogenic? What I mean to say is Entamoeba histolytica is always pathogenic if you get trophozoite? No, they say that Entamoeba histolytica has got 2 subspecies. I mean, now it has got 3 subspecies: histolytica, histolytica. This alone is pathogen, whereas other 2 subspecies are histolytica dispar and histolytica moskowski. Dispar and moskowski are non-pathogen. Histolytica has got 3 subspecies: histolytica histolytica, histolytica dispar and histolytica moskowski. Among the 3, only histolytica subspecies histolytica is a pathogen, whereas dispar and moskowski both are non-pathogen and they may be found as a commensal in your stool. Hence it is very essential to differentiate these 3 subspecies. They say that the cyst and trophozoite of all the 3 subspecies are morphologically similar. You cannot differentiate cyst and trophozoite of histolytica subspecies histolytica from that of dispar and moskowski. Hence, they say that the only way to differentiate these 3 subspecies is best is by doing a PCR. PCR is done to differentiate to detect the specific gene of the respective subspecies. Otherwise, you can look for antigen detection in stool, because they say that lectin antigen, which is the virulence factor, it is only present in Entamoeba histolytica subspecies histolytica, will not be there in other subspecies because they are non-pathogen. Other than that, you can also go for specific isoenzyme detection. Entamoeba histolytica produces various isoenzymes, and the isoenzymes of 3 subspecies are different than each other. So, specific isoenzyme detection by a study called as zymodine study. can be done to detect the respective isoenzymes. What about if you detect RBC inside trophozoid? See, trophozoid may be same, the morphology of trophozoid may be same, but RBC inside the trophozoid is a sign of invasion. So that is positive only for histolytica subspecies histolytica. Fine. And then coming to extraintestinal amoebiasis, the most common site is liver followed by lungs, okay, and in liver the most common site is posterior superior aspect of right liver. This is the most common site, posterior superior aspect of right liver. Okay, so how to diagnose extraintestinal amoebiasis, especially amoebic liver abscess? How to diagnose? Amoebic liver abscess is diagnosed mainly by antibody detection in serum, by PCR, I mean by ELISA, and other methods can be used to detect antibodies in serum. Of course, PCR in liver aspirate, this also is this is of course the best method. PCR using the specific primers to detect Entamoeba histolytica genes in the liver aspirate. Please remember, if you go for stool microscopy, it is even if it is positive, it is non-conclusive. Why? Because stool microscopy, if it is positive, what is the possibility that even the liver abscess is due to Entamoeba histolytica only? It may be some other cause of liver abscess. So stool microscopy, even if it is a positive, it is non-conclusive. What about liver aspirate microscopy? Can you tell me what is the characteristic liver pus is called as? Anchovy-Shaw's pus. Anchovy-Shaw's pus or chocolate syrup. And this particular Anchovy-Shaw's pus, if you do a microscopy, they say that you will get trophozoites or cysts or both. Only trophozoites are seen, never cysts, but the sensitivity is very low. Maybe 10 to 20% is the sensitivity. So PCR and antibody detection in serum, these are the better method for diagnosis of amoebic liver abscess. Fine. Let us now discuss free living amoeba. Okay, before that, drug of choice, can you tell? Entamoeba histolytica, they say that for dysentery, Entamoeba histolytica, the drug of choice for dysentery, it is metronidazole, and for luminal infection, even you can give paramomycin. Okay, invasive also metronidazole, whether it is invasive or dysentery, metronidazole. For luminal infection, luminal infection means it will destroy the cyst, because cyst alone will be there, I mean cyst will be there in lumen, whereas invasive infection, metronidazole is given. So this is all about treatment. Then coming to free